floor is yours.
Hello. Today's lecture focuses on surgical approach to mid-membranous vocal fold lesions. So in my understanding, when we understand the anatomy and the pathology and the technique of surgery here is actually essential, not only for the surgical success, but also for safeguarding of the patient's voice. So let's break down together into the lecture. Mid-membranous lesions of the vocal fold are abnormalities of the lamina propria of the vocal fold with minimal or no change of the overlying epithelium. They are extremely common cause of voice disorders, and the surgical procedures and principle actually based on the vocal fold physiology, specifically the Hirano's cover and body concept. When we see the Hirano cover and body complex, in order to maintain the vocal fold in vibration, the mucosa of the vocal fold has to be more mobile. And this is, of course, attributed to the microanatomy of the vocal fold, the unique, actually, microanatomy of the vocal fold. So in 1977, Hirano proposed the cover body concept of the vocal fold, whereby the mucosal lining moves over a relatively stationary body consisting of the vocal ligament and the muscles. So getting a little bit deeper into the normal vocal fold histology, the most superficial layer is the epithelium, that is the stratified squamous epithelium covering the anterior glottis, and the pseudostratified ciliated epithelium covering the posterior glottis. And then deeper to the epithelium, there's the basal lamina that provides physical support to the vocal fold during the vibration, either the lamina lucida and the lamina densa. And then deeper to the epithelium and basal lamina are the three layers of the lamina propria. The most superficial layer, of course, is the superficial layer of the lamina propria, or the SLP, and is mostly acellular and composed of extracellular matrix protein and fibrous components. And the potential space between the SLP and the intermediate layer is the rhynic space. In this space, there's accumulation, sometimes the accumulation of gelatinous-like fluid, which forms the rhynex edema. So, and then the intermediate and deep layer of the lamina propria form together the vocal ligament, and they are composed mostly of elastin and collagenous fibers. And lastly and deeply, the body layer of the muscle, which is the vocalis muscle, that is the medial portion of the thyroarytenoid muscle. So the vocal fold mucosa and the vocal ligament covering the vocalis muscle extend from the anterior commissure to the vocal process of arytenoids. And then the vocal mucosa and the vocal ligament extend posteriorly to cover the entrity of the vocal process. Thus, the anterior third of the endoscopically visual vocal fold is forming the membranous part of the vocal fold, and the posterior third of the endoscopically visualized vocal fold forms the respiratory or the cartilaginous part of the vocal fold. So normal voice requires the laryngeal function to be coordinated, efficient, and physiologically stable. So the lighter and more mobile mucosa, the more efficient vocal fold vibration, as we can see here in this video. The presence of the mid-membranous lesion of the vocal fold can cause imbalance in this system. So, there are 7 distinctive mid-membranous lesions of the vocal fold nodules, cysts, polyps, vascular malformation, rhynex edema, reactive lesions, fibrous mass, and vocal and bamboo nodes. Actually, mid-membranous lesions of the vocal fold represent the majority of causes of voice disorders, and they are mainly caused by vibratory injury of the vocal fold, vocal abuse or misuse. However, there are other multifactorial incriminated factors like extroverted patients and the patient's occupation, and of course, smoking, acid reflux, nasal allergy, or recurrent upper respiratory tract infection. So let's start with the vocal nodules. They are mainly in the most superficial layer of the lamina propria and the basal lamina of the vocal fold, and they are always symmetrical and bilateral. The vocal fold cysts are encapsulated lesions situated deeply in the lamina propria, actually near the vocal ligament. And then the vocal fold polyps are exophytic growths covered with very thin and atrophic mucosa. The rhinix edema is a gelatinous fluid accumulation into the rhinix space, as we can see here. The reactive lesions are pathological processes that occur in response to a contralateral lesion of the vocal fold, like polyps and cysts. The bamboo nodes are abnormal deposition of material in the lamina propria. Sometimes it's inflammatory material, and this occurs mostly with connective tissue diseases like the rheumatoid arthritis. And then the fibrous mass. What I mean by the fibrous mass is the accumulation of fibrous tissue into the lamina propria. Sometimes they occupy the whole length of the lamina propria, and this is a fibrous mass of the right vocal fold, and this is a fibrous mass of the left vocal fold. So some of the mid-membranous lesions of the vocal folds are, in fact, may respond to the non-surgical treatment modality. However, if you have a patient with severe dysphonia with significant functional limitation, then of course, phonomicrosurgery is indicated. But before rushing into surgery, I'd like to point out certain facts about the surgical approach for phonomicrosurgery. Well, phonomicrosurgery is almost elective, unless, of course, if you have a patient with a large exophytic lesion occluding the airway, there is emergency. So your patient must have participated in an extensive non-surgical treatment modality as voice therapy. And voice therapy here, not only for adjusting the abnormal vocal behavior, but also actually it impacts the psychological stress. You see, patients with voice disorders, those patients are individuals expressing and identifying themselves through their voices. And the possibility that they might need a surgery as their last resort is actually producing some sort of anxiety to them. So voice therapy addresses this psychological effect, and not only just adjust the vocal behavior, but also it relieves this stress and anxiety resulting from the phonosurgery and improve the post-operative patient's compliance. And one important factor also is prior to the phonomicrosurgery, you have to instruct your patient to avoid any condition that creates temporary vocal fold edema, like screaming, shouting, and sometimes lecturing for teachers. And similarly, you have to treat any comorbid medical condition that result in vocal fold edema, like gastroesophageal reflux, like chronic rhinosinusitis, like recurrent upper respiratory tract infection. And I sometimes instruct the patients or give the patients like short oral steroid therapy, like 2 weeks prior to the phonomicrosurgery. And the reason that we should avoid temporary vocal fold edema is that the temporary vocal fold edema actually appears to be potentially pathological. And this increases the amount of vocal fold tissue removal in the phonomicrosurgery. So when you create a vocal fold, when you remove or avoid any condition that creating temporary vocal fold edema, you're actually minimizing the removal of the tissue epithelium or the lamina propria that appears permanently pathological, and thus decreasing the over-aggressiveness of vocal fold tissue removal during the phonomicrosurgery. Another important factor in the surgical approach for these lesions is the less is more approach. So when it comes to phonosurgery, whatever the measure is taken to reduce the mass of the vocal fold, there is an accompanying risk of hindering the vocal fold vibration by vocal fold scarring. So when you are doing phonosurgery, you have to be as conservative as you can. And this is again to minimize the vocal fold, excess vocal fold tissue removal. And furthermore, actually, we have to bear in mind and to accept the possibility that a small percentage of our patient might need phonomicrosurgical repeat phonomicrosurgical procedure. And that is, in fact, a small price that we pay again for minimizing the risk of over-aggressive resection of the epithelium or the lamina propria, and thus a resultant scar formation and worse post-operative voice outcome. Lastly, the post-operative voice risk is actually crucial, and the time for the post-operative voice limitation ranges from 2 to 14 days. I usually advise an average of 7 days, especially if the patient has a large lesion. And well, in fact, for teachers, I might give them voice rest for about 30 days before returning to full speaking voice activities. So it's better to, if you have a teacher during the school year, so it's better to postpone the surgery to the holiday, the mid-semester holiday, or even the summer holiday. So the surgical approach might be done under general anesthesia or under local anesthesia. And actually, some lesions might improve with the local steroid injection. So this is an edited video of a phonomicrosurgery of a 30-year-old female patient with a right vocal fold bilobulated polyp and left vocal fold reaction. So for the upper one, I opted for the microflap approach. I made an epithelial chordotomy at the junction of the lateral aspect of the vocal fold polyp with the normal vocal fold tissue mucosa, and you have to be as superficial as possible. And then I did a blunt dissection to expose the pathological material, and I trimmed the abnormal mucosa. Importantly here that the cut has to be perpendicular to the longitudinal axis of the vocal folds and in a posterior to anterior direction. For the lower one, I opted for the truncation approach, and then I excised it with a micro scissor, again perpendicular to the longitudinal axis of the vocal fold. For their active lesion, again the microflap approach, the epithelial chordotomy, micro dissection using a cotinoid, and try to separate the pathological contents as much as you can, and then re-draping the mucosal flap using an ephedrine-soaked cotinoid, and making sure that all the pathological contents of the polyp are totally excised and the vocal fold edges are straightened. I used here the Pochaire triangular forceps for applying a gentle medial traction on the vocal fold polyps. And this is again an edited video of phonomicrosurgery for a right vocal fold cyst enucleation. And the best approach actually for the cyst enucleation is the microflap approach. This is a female patient, 26 years old. Again, I made an epithelial chordotomy. I usually use a blunt, rounded knife to make the incision at the lateral aspect of the lesion with the normal vocal fold mucosa and the superior aspect of the vocal fold. For the cyst, I'd like to widen the length of the cyst a little bit, to be slightly larger than the lesion, so to give you more space for the dissection, and try to dissect the whole cyst wall to separate it from the vocal ligament as much as you can. I usually do the dissection with a blunt cotinoid, and in this area, of course, you have to avoid rupture of the cyst. However, if it's ruptured, just grasp it at the puncture side and continue blunt dissection in order to separate the cyst from the underlying vocal ligament. This is an important step to avoid recurrence of the cyst. And then I trimmed the abnormal or the excess abnormal vocal fold tissue mucosa and straightened the vocal fold edges. So this is her video endoscopy following the procedure. This is 1 week, I believe. Oh, and this is her voice.
1 2 3 4 5 6 7 8 9 10.
This is before the laryngoscopy, the phonosurgical procedure, and this is her voice following the surgery.
1 2 3 4 5 6 7 8 9 10. بسم الله الرحمن.
And then when we come to the nodules, where I just want to point out certain point here. Nodules are usually responsive to voice therapy and other non-surgical treatment modalities. However, if you have a patient with severe and significant dysphonia with significant and persistent functional limitation, and your patient have already exhausted all the non-surgical treatment modality, then you could do the surgery. For the nodules, of course, the truncation approach is the best approach. So this is a 30T, this is again an edited video. I don't usually do it with this speed. This is a female patient, 32 years old, with bilateral nodules. Again, I opted for the truncation approach. Again, I'm using the fenestrated Boucher forceps, apply gentle medial traction on the nodules, and try to dissect or excise the nodules at the junction of at the base of the nodules, and with its junction with the vocal folds, and try to be as superficial as much as you can and as perpendicular to the longitudinal axis of the vocal fold as much as you can. And again, avoid over dissection. This is really important when it comes to phonosurgery, because your patient is a voice abuser and he depends on his voice mainly to identify himself. So if you have a patient with undesirable or risky general anesthesia, like cardiac patient or whatever contraindication for general anesthesia, or if you have a patient with an appropriate individual anatomical configuration for positioning of the laryngoscope and the microscopic laryngeal suspension, then you might do it under local anesthesia. However, it requires a complete cooperation of the patient, and you have to be more experienced with office-based procedures, and actually it's a teamwork. So enhance one snip approach, and your patient have to have no severe gag reflex. And of course, applying appropriate laryngeal anesthesia. So these are the instruments I use for the office-based procedures, resection techniques. And this is a patient with 45 male patient with left vocal fold polyp. You will see here the left vocal fold. This is during phonation, and of course, this is during menstruation. As I already pointed out, we start with proper laryngeal anesthesia. This is an important step actually in whatever the office-based procedure you're doing. First, by spraying the 2% lidocaine or pentocaine spray, whatever you have, and then by 4% pentocaine or lidocaine spray, like swab, and palpating, of course, the vocal fold that you are going to excise the polyp or the lesion from it. And this is the point of removal. I use a banded handle cutting forceps with cup jaws and curved cutting edge. And this is the moment of removal. And this is immediately after removal. And now let's see the video. This is not edited. This is usual speed. Again, I start with the spraying the anesthetic agent. You will see traces of the anesthetic agent after spraying here. This is the white stuff. And then I apply local anesthesia using cotton applicator. Of course, this cotton is soaked in a mixture of ephedrine and 2% and 4% lidocaine or pentocaine spray, whatever you have. Then I use it to palpate the vocal fold that I am going to do the vocal fold procedure on it. You have to make sure that the laryngeal anesthesia is well applied. And then by using the curved cutting forceps, I just one snip approach of the vocal fold polyp. And an important step here, when you are cutting the polyp using the cup jaws, you have to be tangential. This is tangential to the longitudinal axis of the vocal fold. This is opposite to the MLS. You have to be parallel, not perpendicular. Never, ever pull your polyp in a perpendicular direction. Otherwise, you will risk the mucosa of the vocal fold. You have to be as tangential and as superficial as much as you can. You have to be patient. The patient has to be cooperative, and it needs actually a teamwork between the patient and the surgeon. And then sometimes there's minimal bleeding in the endolarynx. Just ask the patient to cough, and you might use also a cotton, just do a little bit massage using a cottonoid soaked in ephedrine and local anesthetic agent. And ask, of course, the patient to cough. You may ask the patient to gurgle the blood, and well, the procedure is already done. And this is his voice 6 months after the excision. There's no sign for the polyp, normal vibration of the vocal folds. and of course, the patient's voice has already regained. As I've already said, that some lesions might respond to local steroid injection, and the common lesions are the bamboo nodes. However, these kind of lesions are associated with high risk of recurrence even after the steroid injection. So in order for a patient to improve, we might need maybe 2 or 3 sessions of steroid injection. So this is a female, 27 years old female patient with multiple bamboo nodes over her both vocal folds. You will see it here and here. Then, of course, I will inject the vocal folds, each of the nodules, of each of the nodes with steroid. And of course, for a steroid injection, after, of course, applying the local anesthesia or the laryngeal anesthesia for a steroid injection, you have to be as superficial at the base of the lesion as much as you can. Never, ever infiltrate your material down to the muscle. Otherwise, an atrophy of the muscle will be result, and of course, worse voice outcome for the patient. I'm using here triamcinolone acetate, and I'm infiltrating the material in the base of each lesion separately. And for the injection, this is a curved, of course, laryngeal needle I use for injection usually. And for beginners who are starting to do the peroral vocal fold injection approach, some needles are actually marked at the depth of the vocal fold mucosa, the mucosa. And you can even mark it by yourself before introducing the needle. Of course, this needs also cooperation of the patient, applying local anesthesia to the larynx, very important, and of course, experience in performing office-based vocal fold procedures. So I'm applying the material in each vocal fold node separately until you're making sure that all of the nodes of the patients have already been injected. So finally, the blueprint. Well, phonosurgery represents a complex interaction between the superficial layer of the lamina propria and the epithelium to the underlying deeper layer of the lamina propria and the muscle. And in phonosurgery, we're not trading off this interaction. Rather, we are, in fact, creating a balance between improving the dysphonia resulting from the pathological lesion and preservation of the overlying normal mucosa. And the incision, the dissection has to be in the superficial plane as much as you can, with maximizing preservation of the mucosa and the superficial layer of the lamina propria and the epithelium as much as you can. And this is to facilitate the primary healing and avoid the secondary healing and scar formation, and thus better postoperative voice outcome. You have to respect the anterior commissure. So if you have bilateral lesions, you might even want to consider that performing the MLS in 2 sessions to avoid the excessive scarring and synechia of the vocal fold. And another important care has to be taken in consideration is avoid the cookie bite defect in the mucosa of the vocal fold, or the main component of the vocal fold structure. And this is important when it comes to excision of the vocal fold polyp. And again, I just want to say it like maybe 100 times, the less is more approach, the more conservative when you are doing the phonomicrosurgery, the better post-operative voice outcome and the better functional recovery without vocal fold scar. And these are horrible when it comes to vocal fold scar. They are the hardest to manage. And lastly, the microflap approach is the best approach to management of submucosal vocal fold pathology. So if you have any questions, if you have like more condensed reading, well, I've authored this chapter in endoscopic surgery for benign vocal fold pathology, and this is included in the book Updates in Otolaryngology. You can use this link for a free download of the chapter, and this is my email attached if you have further inquiries. Thank you so much for your attention.
Thank you very much, Dr. Reham.